Hi, I'm Maureen Richards, and this video is about the organism Streptococcus pneumoniae. So, Streptococcus pneumoniae is the most important, but not the most common cause of bacterial pneumonia. There are other causes of pneumonia that happen more frequently that can lead to atypical pneumonia or typical pneumonia that we'll talk about in other videos. But this one is kind of the most important one that you need to be aware of because of the severity. It's a highly inflammatory organism. Just like the viridans streptococci, this is a non-groupable organism. So remember in the other videos talking about group A strep or group B strep, that was based on the Lancefield groupings, which is determined based on the carbohydrates that stick out of the capsule that we make IgM antibodies to. Streptococcus pneumoniae, those C carbohydrates are hidden, so we can't make antibodies to the carbohydrates. It's an alpha hemolytic organism. What does that mean? That means you're going to get that kind of slightly green tinge on the blood plate agar. So that's where it becomes kind of difficult to distinguish the viridans streptococci from Streptococcus pneumoniae, right? Because group A strep is beta hemolytic, group B strep is beta hemolytic, but the viridans strep are alpha hemolytic, and so is Streptococcus pneumoniae. And they don't have a group, so you need to have other ways for recognizing them. When it grows, you can see it grows in kind of these short chains, but it can also grow in diplococci. The other thing is we call it a cocci or a coccus, but really it's not truly coccoid. It's kind of lancet shaped. So you can see here it's got kind of like this almost like bullet shape here. So that can be slightly helpful in determination, but as you can see, these organisms are pretty small, so you might not be able to recognize its lancet shape. However, it is optogen sensitive. So remember that optogen is kind of a copper salt that you coat on a disc and plate on blood agar. And then when you plate it on blood agar with the optogen disc, you'll see kind of a zone of inhibition around the disc whenever Streptococcus pneumoniae is growing. And that's one way that you can differentiate it from the viridans streptococci, because the viridans streptococci are optogen sensitive. Another way that you can differentiate it is bile solubility. I talked about that as well in the viridans streptococci video. So basically it will be lysed by bile, whereas the viridans streptococci will not. That is one way that you can differentiate the two organisms. It's not typically done. We don't typically have a whole bunch of bile just hanging around in the lab, but theoretically that is a way that you could differentiate Streptococcus pneumoniae from the viridans strep. So this is the same image that I showed in the viridans strep group, but just briefly, this is an optogen disc, and you can see that S. mitis is optogen resistant, so it's growing right up to the disc, while S. pneumoniae is optogen sensitive, so you're getting a nice zone of inhibition. You can also note the alpha hemolytic property of both the viridans streptococci and strep pneumo. I think First Aid has the mnemonic device that viridans streptococci grow in your mouth, so they're not afraid of your chin. I don't really love that as far as mnemonics go, because strep pneumo can actually be normal flora of the oropharynx for about 30 to 35% of people. Especially, it's much more common to see it as normal flora in children. So you just kind of have to be careful about that one. You don't want to go around thinking that you might not find strep pneumo in the mouth. There are 90 different types of strep pneumo, and they are identified based on basically immunologic differences in a complex polysaccharides that make up the capsule. This is the other test that I talked about in the viridans streptococci video. This is the bile solubility. You can see that the viridans streptococci are not being lysed, whereas the strep pneumo are being lysed, so you can see right through them. Again, this one isn't really done all that often anymore. All right, so I mentioned that there are about 90 different types based on the immunologic differences in the complex polysaccharides that make up the capsule. This is kind of important because only the encapsulated strains are pathogenic. And of those strains, about 23 of them make up the majority of human disease. In fact, they account for about 88% of bacteremia and meningitis in adults, when we're talking about, obviously, bacterial meningitis. So it's a pretty important organism, and the antigenic diversity of the capsule actually plays a pretty big role. So strep pneumo can colonize the oropharynx, and in specific situations, it's able to spread to the lungs, the paranasal sinuses, or the middle ear. And it also can be transferred to distal sites like the brain. So when we're thinking about the structure, you need to remember that the way that strep pneumo causes pathology is that it's really just highly inflammatory. It's a very inflammatory organism. So you wind up getting mass inflammation, and anytime you have mass inflammation, you're probably impinging on the function of an organ and its ability to do its job and keep us healthy. So we already talked about the capsule a little bit. C antigen, this is not the C carbohydrates that we talk about, because remember, this is not a Lancefield groupable organism. But the polysaccharide capsule is really great at precipitating C-reactive protein. Recall that C-reactive protein is relatively low in healthy individuals, but it spikes really quickly and really highly in the acute inflammatory state, which is kind of more evidence about how inflammatory this organism is. So it's going to, when you have a lot of C-reactive protein, you're going to recruit a lot of white blood cells and other factors to a specific place. The next thing is these teichoic acids. The organism has these, and it basically activates the alternative complement pathway. And remember, the alternative complement pathway can be pretty damaging. Anytime we're talking about complement, we're talking about, first off, creation of opsonins, right? That's the most important thing that complement does. But we're also talking about production of things like C5a and C3a, which are anaphylatoxins. So they're going to lead to production of a lot of different cytokines, as well as recruitment of things like neutrophils and other phagocytes. This organism actually has something pretty neat, a secretory IgA protease. So I already mentioned that this organism colonizes the oropharynx and can occasionally move into the sinus cavities. So that means it's hanging out in the mucosa. The immunoglobulin that is most responsible for protecting our mucosal sites is IgA. So what IgA normally does is it grabs onto a bacterium and then traps that bacterium in the mucus, and then the cilia kind of bat the bacteria out of the way. However, in this case, this organism just breaks up IgA with its protease, thus preventing the ability for the organism to be removed. There are only 4 bacteria with an IgA protease. This is one of them, Streptococcus pneumoniae, but Haemophilus influenza and the 2 Neisseриas, Neisseria meningitidis and Neisseria gonorrhea, also have IgA proteases, and it's kind of a neat evasion strategy of these organisms. The last thing is pneumolysine O. This is actually a toxin, and it's produced by strep pneumo, and it basically causes damage to the epithelium. And it also has kind of an added benefit of inhibiting the oxidative burst that phagocytes do to basically kill organisms. So basically they require that in order for it to destroy the organisms it engulfs. So it inhibits the leukocytes' ability to do that. This also will activate the complement pathway, and anytime you're activating complement, once again, you're getting opsonins, C5a, C3a, and really systemic inflammation symptoms. So that's going to lead to secretion of your inflammatory triad, IL-1 beta, TNF alpha, IL-6, interferon gamma, anything that's going to lead to increased vasodilation, vascular permeability, fever, and all of those things that make us feel really, really awful. So one of the interesting things to note about strep pneumo is this Quellung reaction, and yes, it is a U, it shouldn't be an I, that isn't a spelling error, it is Quellung. So I already mentioned that strep pneumo has this interesting capsule around it. Well, we make antibodies to the capsule, and remember there's all these different serotypes. Well, when antibodies attach to the capsule, it actually allows for water to like swell in. So you get this like swelling, almost like a water balloon. It just like fills it up, and you can visualize that obviously as we're doing so here. This isn't normally done as part of diagnosis, but it is done during basically vaccine development so that we can track the different serotypes of strep pneumo that are regularly circulating within the community. There are vaccines for strep pneumo, but because there are so many different serotypes that account for human disease, we've had to be pretty creative in putting all of these different serotypes together. So there's a 23-valent pneumococcal polysaccharide vaccine that is used for children 2 years and older through adults, and that's because it contains T-independent antigens. It's really only polysaccharides, and remember, T cells only make responses to proteins. So really all we're creating here are IgM antibodies, right? Because we can't get to any of the other immunoglobulins without any T cells. Because there are no T cells involved, it's really not as effective in patients who have some sort of immunodeficiency or patients who have reduced cell-mediated immunity, because you're not getting as strong response. So it's not as effective in patients with asplenia, a hematologic malignancy, HIV infection, elderly patients, or renal transplant patients. And when I say asplenia, I could mean a lot of different things. So, there are some patients who had their spleen removed due to trauma or some maybe cancer or something. There are also patients who have like a functional asplenia, like patients who have had sickle cell. So those patients, this vaccine won't work very well on. So we have another vaccine, that's the 13-valent conjugated pneumococcal vaccine, and that can be used fairly effectively in infants through 2-year-olds and any patients who have some sort of cell-mediated immunity deficiency. This one requires 4 doses. Typically it is given to children at 2 months, 4 months, 6 months, and then 12 and 15 months as well. So I mentioned earlier that Streptococcus pneumonia is actually normal flora in about 30 to 35% of individuals. So that should tell you that there are places where strep pneumonia can be within your body where it's fine and you're not going to have any sort of negative repercussion of its presence. So what that also tells you is that there needs to be something that either moves it to a site where it's not supposed to be or makes you more susceptible to its inflammatory effects. And that's true. There are basically some significant predisposing conditions that basically make it so strep pneumonia is a problem. So typically strep pneumonia hangs out in your oropharynx. But there are conditions that basically lead to it settling within the lungs, and that's where we see this significant inflammatory response and where a lot of the pathology comes from. The biggest one that we talk about and think about the most is antecedent influenza. Every year during flu season, hundreds, at least probably thousands of people wind up hospitalized from the flu. And many people die from the flu every year. People often don't really think the flu is that big a deal. Flu is an incredibly deadly virus because it's it's probably the virus that has killed more people in this world than any other virus, because it does so every year. But it isn't often the flu virus that's killing patients. It's that the flu virus makes them more susceptible to things like pneumonia from strep pneumo. So what happens is the flu virus lyses epithelial cells, it kills cilia, or damages them, and that makes it so that strep pneumo isn't normally cleared out. It isn't pushed upward, and now it has access because the epithelium is damaged. And that basically allows it to get into the lungs and cause pneumonia. A similar phenomenon occurs with COPD, where maybe the cilia aren't working as effectively. CHF, these patients often have trouble fully exhaling, respiratory problems. Anytime you're not having full use of your respiratory function, you are more at risk for streptococcal pneumoniae infections. Alcoholism is an interesting one. The most common cause of pneumonia in alcoholics is Streptococcus pneumoniae. However, alcoholics in general are at higher risk for bacterial pneumonia. And there is another organism, Klebsiella pneumoniae, which is also famous for causing pneumonia in alcoholics. It's not the most common, but it is a very common cause of pneumonia in alcoholics nonetheless. Asplenia, I already kind of mentioned that one. People who lack a spleen, variety of reasons, right? Functional asplenia, like sickle cell with the microinfarcts in there, inhibiting the function, people who have it removed. So all of this makes people more susceptible to strep pneumo infection. These people who are asplenic might wind up with sepsis from Streptococcus pneumoniae. Why? Well, the spleen is a filter. So normally it filters out phagocytes and antibodies that have attached to strep pneumo and made it so that they can leave the body effectively. But if the spleen is gone, you're getting less filtration, and you can live without a spleen just fine. You're just more susceptible to some bacterial infections like Streptococcus pneumoniae. And then the other one that is routinely brought up is individuals over the age of 65. That automatically puts you in a higher susceptibility range for Streptococcus pneumoniae. So disease occurs when organisms colonizing the nasopharynx and the oropharynx spread to the lungs, paranasal sinuses, ears, or meninges. Spread of Streptococcus pneumoniae into the blood or another body site can occur with all of these diseases, but it is recognized that some serotypes have a higher predilection for an invasive pneumococcal disease than others. Okay, so let's talk about the diseases that strep pneumoniae causes. First off, this one's kind of a gimme. It causes pneumonia. It's the most common cause of typical bacterial pneumonia in adults. So what do I mean by typical pneumonia? You could see some hemoptysis, so it's a productive cough with rusty sputum. Lobar pneumonia, consolidations, you can see this white patchiness down in the lower quadrants of or in the lower lobes of the chest x-ray. Patient obviously is going to have difficulty breathing with all of this going on. Sometimes patients will be in pain, myalgia, because you're also going to have spiking fevers, big spiking fevers. So that's kind of typical pneumonia. With typical pneumonia, you're not walking around, you're barely getting out of bed, you're having difficulty breathing, you're either flat in your bed in the hospital or at the doctor waiting to go to a hospital or go to bed. This isn't really a disease you fight your way through. Patients will say things like, I was too sick to get out of bed, I was too sick to go to the doctor. So it can be a very difficult disease to get through. This differs from atypical pneumonia. Atypical pneumonia is something you'll hear a lot about in the winter. We'll talk about it again when we talk about Mycoplasma pneumoniae. Patients with atypical pneumonia, they basically have this prolonged, dry, hacking, non-productive cough, like they'll have some fevers that come and go, and they'll come to work or school and they'll sit in the back of the room coughing all day long. And you're like, oh my gosh, as you're hearing them cough, if you're that sick, just go home. But they come in day after day because they're not so sick that they can't come in and infect everybody else. So they do it day after day, and eventually you're like, oh my God, just die already or get better. No, you guys don't say that. You're going to be doctors, so you probably don't say that. But either way, continue to cough for weeks and weeks, but they're okay. They can still go about. That's atypical pneumonia. It used to spread quickly through crowded lecture halls, but now we don't have lecture halls. So you guys are completely safe in the comfort of your own home, even if you have atypical pneumonia right now. So for community-acquired pneumonia, and I'm talking likely typical pneumonia, as a monotherapy, you can use levofloxacin. But if you're going to do multi-therapy, you can add in either like azithromycin or ceftriaxone and vanco, just depending on the severity of your patient. Okay, I mentioned earlier that strep pneumo could be an invasive disease. It is the most common cause of bacterial meningitis in adults. Typically people older than the age of 40. If they are 20 years or younger, so if we're talking like adolescents to 20-year-olds, it might be, it's more likely to be Neisseria meningitidis. If they're infants, then there's a whole different set of organisms, including group B strep or E. coli, but for less than 20, it's N. meningitidis, but older than 40, S. pneumonia is the cause of most bacterial meningitis cases. You need to be able to differentiate between bacterial meningitis and viral meningitis. There's kind of two reasons for that. One, bacterial meningitis, you can do something about. You can treat bacterial meningitis. We have antibiotics. If you identify it early, the patient can be treated and likely will have no long-term sequelae as a result of it. Viral meningitis, for most of them, with the exception of herpes simplex virus, we can't do anything about it. Like we don't have treatments. It's just supportive. Bacterial meningitis often also tends to be much more severe. So if you miss bacterial meningitis and you don't start treating it early enough, the patient could die. The patient could have severe neurologic complications for the rest of their life. Viral meningitis, which can be very severe, is not typically as severe as bacterial meningitis. So you can't miss this. So how can you kind of tell them apart? Well, first off, you're going to do a lumbar puncture. You're going to collect the CSF. And when you look at the CSF, it's going to have a high amount of polymorphonuclear cells, so a high amount of neutrophils. And those will be big and evident. You'll be able to tell, the pathologist will be able to tell the difference in the nucleus. It's going to have a high protein concentration and a low glucose concentration. You'll see this. It's kind of key for diagnosing bacterial meningitis because there are some bacterial organisms that cause meningitis where you might not see the organism on the CSF. So with strep pneumo, you are likely to see the gram-positive lancet-shaped diplococci on the CSF, but you can't always rely on that. If you see, something that has white cells, but the protein is slightly elevated and the glucose looks normal, then it might be viral, it might be fungal, but if it's all three of these, you can't wait, you have to treat, and you need to diagnose what it is quickly. There are empiric guidelines for treatment of bacterial meningitis. At where we practice, it's or where you guys will begin practicing, it's vancomycin and ceftriaxone right now, but your infectious disease clinics will put out kind of the susceptibilities for organisms throughout the year. All right, and the last thing that Streptococcus pneumoniae causes is parents calling in sick to work. Literally, it is the most common cause of otitis media or ear infections and sinusitis or sinus infections in children. Therefore, it is probably the most common cause of lost wages for parents. These are pretty self-limited, easily treated, and generally children will recover and all will be fine. So those are the diseases, pathogenesis, and structure of Streptococcus pneumoniae.